A very good morning and Salam University Watan UKM to all our highly esteemed professors, consultants, specialists, as well as all our colleagues who are joining us on this morning. Today we have a very interesting case that we are going to be discussed in this clinical pathological conference regarding a middle-aged lady who presents with transaminitis, but indeed as the story unfolds, there is more than meets the eye, and the transaminitis is merely a wolf in sheep's clothing. Our discussant today is Dr. Gary Lee Chearn, who is our fellow in the Gastroenterology and Hepatology unit with an interest in EUS and ERCP. And our other discussant is Dr. Syahrul, who is a registrar and an internal medicine resident in the Department of Medicine, UKM. Our highly esteemed panel consists of experts both nationally and internationally, and we would like to introduce them, beginning with Prof. Rosmawati Mohamed, who is a senior consultant in the Department of Gastroenterology and Hepatology, Faculty of Medicine. Our other panel is Professor Isa Rose, who is also a highly esteemed professor and the pioneer of gastrointestinal pathology in the country. And lastly, our last panel is Dr. Ho Shuang Yi, who is a radiologist with a special interest in MRI from the Department of Radiology, Faculty of Medicine. So without further ado, I would like to hand this time over to Dr. Gary, who will start his presentation regarding this interesting case. Gary, the floor is yours.
Okay. Can everyone hear me?
Yes, we can, Gary.
Okay. Yeah. Thank you, Dr. Deborah, Chairman, for today's CPC. Without much further ado, we will start today's session. Yeah, we have a lady, Madam H, 43 years old, who was known to have seropositive rheumatoid arthritis diagnosed 3 years ago. When she presented with joint pains involving small and large joints, specifically over the both hands. So she was referred, she was initially managed with the rheumatology team and noted that there's persistent transaminitis since June 2020, with the range between 1 to 2 times upper limits of normal. So my first question to Dr. Syahrul is, what symptoms would you like to obtain from the patients? Imagine you are the registrar in the gastro clinic, seeing the patient for the first time.
Okay. Assalamualaikum and good morning, everyone. So basically, this one is a middle-aged lady with a non-case of seropositive RA, and then presented to us with transaminitis. So actually, what symptoms I like to obtain from this patient? Actually, basically symptom of hepatitis, such as lethargy, and also vomiting, and also loss of weight, loss of appetite, and also weight gain for this patient.
Okay. Thank you. So for the first time, when we see the patients, we would get some history, basically the symptoms. So I will give you the findings or the symptoms elicited from the patient. During that time, patient is asymptomatic of hepatitis. There is no abdominal pain, no nausea, no vomiting, no diarrhea. There is also no symptoms of obstructive jaundice, no pruritus, dark urine or pale stool. Patient also denies having fever. There is no fatigue, loss of appetite, loss of weight. But she did have on and off small joint pain, specifically of both hands as well as the ankle, with the pain score of 3 out of 10. So moving on, what further history would you like to obtain from the patient?
Okay, at this point of time, actually my differential at this point of time at first is acute viral hepatitis. The second one is autoimmune disease, autoimmune hepatitis, and also the drug-induced liver injury, maybe secondary to DMARS, and also the DMARS, and also the traditional medication, and also the fourth differential is metabolic associated liver fatty disease. So from this, I want to obtain is actually what the study of previous history of any surgery or blood transfusion or any tattoo, and also family history of hepatitis, and also maybe history of high-risk disease such as IVDU. Regarding autoimmune, I want to ask regarding any other onset of mouth ulcer and also hair loss and also weight loss. And then regarding I want to take the full history of the drugs, particularly about the DMARS that she used for the RA. And also I want to ask regarding all the supplement and also traditional medication that's in my take. And then lastly, I want to ask regarding the metabolic history of any dyslipidemia or diabetes for this patient.
Okay, so there are a thorough history that we have to obtain from the patient, aside from the symptoms. So I think Syahrul raised about presence of symptoms of connective tissue disease apart from the joints symptoms. So apparently patient doesn't have, there's no alopecia, no mouth ulcers, no other rashes of note. As to the risk factors, specifically for viral hepatitis A, B, and C, there is no high-risk behavior, no IVDU, no multiple sexual partner, no history of blood transfusion, no travel history, no history of recent shellfish ingestion, and there's no alcohol intake. So for past medical history, we managed to explore more. She has a well-controlled hypertension for the past 30 years, but also has dyslipidemia. She was newly diagnosed type 2 diabetes mellitus since early 2022 with the HbA1c of 6.3. We did explore in detail her drug history for the past 3 years, where her long-term medications would be amlodipine, simvastatin, metformin, as well as sulfasalazine and prednisolone, which was EOD dosing of 5 milligrams. When we explore further, we noticed that prior to the visit to our gastro clinic, she did has a history of taking supplementations of Shaklee Herbalex for 10 years. But she did stop in 2020 after noted there is a transaminitis and advised by the rheumato doctor. So she was started for a short duration of lecithin, and she had a history of taking tofacitinib for the rheumatoid arthritis, but stopped due to side effects. Same goes for methotrexate. And for the recent 3 months, there is no over-the-counter medications for any URTI or other condition. So we did explore about other history of surgical history. She did have a cesarean section 3 times prior to that, and she had 3 children aged of 13, 12, and 10 years old. For all the deliveries was uneventful for elective cesarean section, but she did have a stillbirth secondary to impending eclampsia and abruptio placenta. When we explore the family history, she had a strong family history of autoimmune disease, which include SLE and rheumatoid arthritis. There is no consanguinity between her parents. For social history, she is married with 3 children, and she works as a medical lab technologist in the blood bank. So, Dr. Syahrul, what physical findings would you like to elicit from this patient?
for physical finding for this question, generally I want to see any source of any connective tissue disease, and also such as and also I want to like the presence of jaundice or what. And then by the abdominal examination, I want to see if any hepatomegaly and also any signs of chronic liver disease such as ascites and also spreading by like that. And also I want to see any the lower limb edema. And apart from that, I want to see the phenotype of any metabolic disease such as obesity for this patient.
Okay, so for physical examinations, patient is alert pink, not jaundice. She has a normal vital signs, and her body mass index is 34 kilograms per meter squared, which is in the obese category. She has no stigmatas of chronic liver disease, no pedal edema. She has abdominal examinations, reveals no hepatosplenomegaly, and there is no presence of ascites. So what other lab investigation would you like to send for this patient?
Okay, for this patient, I want to see the basic investigation such as FBC and also RP and LFT, and also coagulation profile for this patient. In terms of etiology, I want to send the first to investigate any viral hepatitis. So I wish to send heavy S antigen, heavy S antibody, and also anti-Hep B core, and as well as anti-HCV. So for voting up for autoimmune hepatitis, I want to send for serum ANA and serum asthma, and also serum IgG level. And apart from that, I want to screen for metabolic status for this patient. So I want to send HbA1c, fasting serum lipid, and fasting blood sugar for this patient.
Okay, so we sent full blood count for these patients, and hemoglobin is around 11. Further on, we did send liver enzymes. Bilirubin, as we note here, it is normal, and ALT was always between 60 to 70. It did come down, improve slightly to 40 at the past 6 months. ALP, all the while, it was normal range, and the albumin is normal. She has a normal creatinine. And for the fasting lipids, we do note that there is a raised LDL in the end of 2020, which remains a borderline high throughout. Triglycerides is between 1.5. Yeah. So I did have a timeline chronology as to her blood levels, as well as possible medications that she was on to look for any possible interactions. Patient admitted to having taken before the first clinic visit, and since then she has stopped. And during the time she has a rheumatoid arthritis, she was prescribed prednisolone, sulfasalazine, and there was a 1-month course of Legalon. ALT that time was around 70 with the LDL raised. Subsequently, she stopped Herbalex, continuing with the same rheumatoid arthritis medication. And we noticed that there is persistence of ALT despite she has stopped the Herbalex even after 2 years duration. So henceforth, the timeline may not fit with drug-induced liver injury. Moving on, in 2021, there was added tofacitinib as well as methotrexate subsequently, but she was unable to tolerate these medications due to side effects. HbA1c is 6.3%, and the viral screening B and C was negative. IgG was sent 2,370, which is 1.5 times upper limit normal. IgA, IgM normal. ANA initially negative, but repeated 2 years later, it was significant, 1 to 320 speckled. AMA is negative, ASMA negative, And we did calculate a simplified AIH score of 6, which is indicates a probable AIH. So moving on, what imaging investigation would you like to order for this patient?
At this point, I want to order for ultrasound HPS to look for any vocal libulation. And also for, so this is possibility of muffled for this patient. So I want to see for any distinct epigenicity in the liver HPS and also any extra hepatic biliary obstruction.
Okay, so before ultrasound discussion by Dr. Ho, we did request for a fibroscan for this patient, and with the CAP score and liver stiffness values as noted. So, Dr. Syahrul, would you like to interpret the fibroscan results?
This fibroscan. So what we ask regarding the CN paper, this is actually called for antenatal parameters to see any cirrhosis in the station. So this is 271. So this is S2 S2 class for it, which means that it have about 30 to 60% liver deposition, fatty deposition. And then regarding the elastography, this is a 9.4 kPa. So this is some sort of fibrosis for the patient, and then about stage F2 for this patient.
Okay, that's right. So yeah, moving on, shall we invite Dr. Ho to discuss about the ultrasound findings for this patient?
Thank you, Dr. Lee. I'll share my screen.
Oh, yeah.
Good morning, everyone. So I'm Dr. Ho from Radiology Department. Today, I would like to share a bit of the imaging part on metabolic associated fatty liver disease, or known as non-alcoholic fatty liver disease. This disease is always associated with diabetes mellitus, obesity, dyslipidemia, or hypothyroidism. So for this fatty liver, it's actually subdivided into two types, which is a simple steatosis or non-alcoholic steatohepatitis. For simple steatosis, there's just simple fat deposition within the liver. But as for a steatohepatitis, because of the inflammation, the liver will progressively forms fibrosis and subsequently cirrhosis. So in a background of cirrhosis, the patient actually have a 2 to 20% 5-year cumulative incidence of hepatocellular carcinoma. So it is important to identify this disease. So for gold standard of quantification of a liver steatosis and also the diagnosis of a steatohepatitis, actually it is a liver biopsy. However, liver biopsy is invasive, and there's also possibility of sampling error because of a non-uniform distribution of the fat deposition. And as well, it is not a practical thing to do for a screening purpose. So it comes the role of imaging. From the imaging, we will be able to demonstrate fat deposition in the liver, and also from imaging, we can identify the presence of liver cirrhosis. Just for the information, the conventional imaging does not provide information the degree of a fibrosis. So now I just discussed a bit briefly about these 3 conventional imaging methods where we use for fatty liver. So the first is ultrasound, second, computed tomography, and third one, MRI, magnetic resonance imaging. Amongst these three modalities, I'll now briefly mention about what is the advantages and disadvantages of the different modalities. For ultrasound, we have a sensitivity up to 80% to detect fatty liver. So it is widely available and easy to perform, and it's also not expensive to perform this modality. However, the disadvantages is because ultrasound is operator dependent. And also if the patient have a high BMI value, it's difficult to perform the ultrasound. And also in the case of mouse steatosis, ultrasound is relatively less accurate. As compared with a CT, we can see the sensitivity is almost the same with a sensitivity for CT in detecting fatty liver up to 82%. For CT, it is also widely available and easy to perform. But because of the potential radiation hazard, we seldom use a CT for a screening purpose. And as well, similarly as an ultrasound, it is less accurate in detecting mouse steatosis. And as for MRI, the sensitivity is higher, up to 90%, and it's highly accurate and reproducible. And it can also measure a very low degree of fat deposition. However, the disadvantages is because it's high cost and also the long examination time. We seldom use MRI in detecting the disease. It is more of a study value. Now I'll be showing ultrasound and the different grading of ultrasound grading for liver steatosis. So we have grade 0 to grade 3. Grade 0 is normal. So you can see here, this is the liver. L is the liver, K is the kidney. So they should have a similar echogenicity. So this one is a normal liver parenchyma, how it should look like. So in a mild grade 1 liver steatosis, you can see the liver echogenicity is actually higher than the adjacent kidney. So this is the grade 1. And for grade 2, which is moderate, you can see that the definition of the water vein wall is not so well delineated. So this is in keeping with a grade 2 liver steatosis. And as for grade 3, you can see the entire liver is very echogenic until you cannot delineate the diaphragm. So this is how we grade the liver steatosis according to ultrasound. So for this patient, she had done an ultrasound, and from this ultrasound, where you can see the liver actually has slight increased echogenicity compared to the adjacent kidney. So this patient actually have a grade 1 liver steatosis. As well, when we do the ultrasound, we find that this patient does not have a stigmata for cirrhosis. The liver margin looks fine, and there's no evidence of a portal hypertension. And there's also one incidental finding of a simple liver cyst at segment 5 of the liver, measuring 1 centimeter. Just a bit discussion on the CT. This patient doesn't have any CT done, but I would just like to mention a bit about how we interpret the CT for fatty liver. So we know that different organs have a different attenuation value in CT. So for liver, the normal range usually is between 50 to 60 HU. And as for spleen, it's between 40 to 50 HU. So you can see the difference. Usually the liver should be roughly about 10 HU higher than the spleen. So how we measure the fatty liver in CT? We can measure by 2 methods. One is the absolute liver attenuation value. So that means we know the normal value of the liver attenuation. If the value is less than 40 HU, we will diagnose that this patient actually have a fatty liver. And another method is actually liver to spleen difference in attenuation. That means you try to see the difference between the attenuation of the liver and spleen. If there's more than 10 HU less than the spleen, that means the patient have a fatty liver. So I'll just show you an example. For this one, on the A is actually a normal CT patient with a normal CT. You can see the liver have a normal range of the HU 65, and also the spleen is 50. So the value is no less than 10. So this is a normal CT. So on B, you can see the attenuation of the liver is actually 10.5. So it's lesser, much lesser than the value we should usually receive. And also you can see there's difference more than 10 HU compared to the spleen. So this patient actually have a fatty liver. But last but not least, I just mentioned a bit about MRI. We use a chemical shift effect and also fat saturation to actually study fat deposition within the liver. So this is just an image to show, this is a Dixon method. I should just show an example of a MRI where you can see the sun image have 4 different images. One is a water only image, and this one is a fat only image, and we have in phase and out of phase. So when we compare this in and out of phase images, if you see on the out of phase image, because of the cancelling effect of the proton within the water as well as fat, so if there's fat deposition, you can see actually there's a drop of signal within the liver parenchyma. So in conclusion, patients with non-alcoholic fatty liver disease are at risk of steatohepatitis and progressive liver fibrosis, culminating in cirrhosis, typically over a period of decades. So early diagnosis and risk stratification are essential for effective management. So at the current era, ultrasound still remains the mainstay for screening purpose. Here are my reference, and thank you very much for your attention.
Okay, thank you very much, Dr. Ho, for the very detailed description on the imaging. So let me just share screen. Okay, back to Dr. Syahrul. From the earlier case presentations, we noticed that the anti-nuclear antibody is positive in these patients, as well as a raised IgG of 1.5 times upper limit normal. So what other investigation would you order for this patient to confirm the diagnosis?
At this point of time, so I still have a probable autoimmune hepatitis as well as narco. So the best investigation to confirm the diagnosis and to settle our diagnosis is liver biopsy.
Okay, that's correct. So we do have indications for liver biopsy in this case, and to explore other possible indications of liver biopsy, I will just illustrate a few points. So liver biopsy can be requested if there is an uncertain diagnosis and evaluation for dual etiologies. This is also essential for the diagnosis of NASH and prerequisite for diagnosis of autoimmune hepatitis and used to guide treatment decisions. It can also help to prognosticate the liver condition, whether there's presence of fibrosis or cirrhosis. And liver biopsy is also indicated as if non-invasive tests showed indeterminate or non-concordant results, and if the patient is scheduled for an abdominal surgery and during research. So shall we invite pathology team to discuss about the liver biopsy in this case? I shall stop sharing.
Assalamualaikum and good morning, everyone. Can you guys see my slide and hear me clearly?
Yes, we can.
Okay, so I'm Farhan bin Ibrahim, a doctor from Department of Pathology, Histopathology Unit. So I'll be discussing the HBE findings for this case. So macroscopically, we received 4 cores of liver tissues, and which was entirely submitted in one block. Under lower power, we can see the presence of 4 core of liver tissue, and they will display preserved lobular architecture. Just to refresh the anatomy or the histology of the liver, this is the hexagonal pattern of the liver lobule. At the center, there's presence of central vein, and at the periphery, there's presence of portal tract, such as maybe over here. You can still see the architecture of the liver. Under higher power, we can see the presence of 24 portal tracts, and these portal tracts show mild portal inflammation, which are predominantly of chronic inflammatory cells, which are the lymphocyte and very occasional plasma cells observed, such as over here shown in the picture. So this is a higher magnification times 40 times 400. However, there's no obvious interface hepatitis observed, and the bile ducts appears unremarkable. This is probably this is the bile duct over here. Other than that, there's also presence of mixed macro and micro vesicular steatohepatitis of the hepatocyte, and these involve approximately 70% of the liver parenchyma. This is times 20. You can see there are a lot of steatohepatitis. There's a steatosis occur. Some bigger one, the macrovesicular, while the smaller one is the microvesicular. This is a higher power as well. You can see the presence of the macro and micro hepatitis. Okay, so in this higher magnification, we can see the presence of ballooning hepatocytes, such as over here, over here, over here as well. Okay, and there's also presence of mild scattered lobular inflammation. However, there's no acute inflammatory cells, which are the neutrophils seen, such as over here. There's like lymphocyte aggregates, a bit over here, and over here as well. Here, similar finding to the previous descriptions, just very mild lobular inflammation, which are composed of a lymphocyte. There's no acute inflammatory cell seen. So this is our special stain, which is the mesenteric which shows foci of perisinusoidal fibrosis, such as over here. The fibrotic area is reflecting by the bluish area here as well. So going to our differential diagnosis, so this would be the typical histological features that we will look for when we want to rule out autoimmune hepatitis. The first one, there's a presence of a portal plasma cell rich inflammation. There will be interface hepatitis, or formerly referred as piecemeal necrosis. Piecemeal necrosis. There will be enteropolysis, which is an active penetration of the lymphocytes into and through the hepatocyte. There will be hepatocyte rosette, which indicates the hepatocellular regeneration following lobular injuries, variable degrees of fibrosis, and lobular necroinflammatory activity, which usually accompanied by portal or periportal inflammation. So this is an example of picture that I took from an article which shows presence of interface hepatitis. PT is the portal tract, and we can see the presence of lymphoplasmacytic infiltrate extending into the lobule. So this is the liver parenchyma. They are trying to the inflammatory cells is going into the liver parenchyma. So this is a higher power, and the arrows are showing the presence of plasma cell. These are plasma cell, and these are lymphocyte as well over here as well. So hepatocellular rosette, it is denotes by this dark circle. It looks like this, some sort of like this rosette. And then enteropolysis arrow, that is the lymphocyte. And this table is showing the NASH showing the network scoring system for non-alcoholic fatty liver disease. So for this case, the steatosis grade, as mentioned previously, is like around 70%. So it's already scored 3, as it is more than 66%. There's mild lobular inflammation, which is less than 2 foci in ×20 field. And there's presence of hepatocellular ballooning and fibrosis is 2 lah. We give the score of 2. And so the total score is 6. Score of 5 or more might suggest a presence of NFLD. As for our fibrosis score, which we use the mesenteric to identify, it is 1A, which is mild, and it is delicate, zone 3, perisinusoidal fibrosis. Going into our other differential diagnosis, which is drug-induced hepatitis, the following are the histological feature, the typical histological feature that we look for. We want to rule out drug-induced hepatitis. The first one is the presence of chronic hepatitis pattern by mixed portal inflammation. Some drugs such as amiodarone, methotrexate might cause fibrosis and cirrhosis of variable degrees. There's a steatohepatitis as well. And some of the drugs mentioned here might cause cholestatic injury with inflammation such as allopurinol, cimetidine, ibuprofen, and so on. Other than that, they may also we might also look for presence of bile duct injury, ductopenia, and cholangitis. So all in all, for our case, these are the scoring that I've mentioned previously. It is consistent with NFLD. And as for discussion, I will pass it over to Prof. Isa to discuss further regarding this case. Thank you.
Okay. Assalamualaikum and good morning to everyone. I think I'll probably focus my discussion for the next few minutes on this slide, which is probably quite an encompassing slide. Now, as mentioned, the histology that was showed previously showed steatosis and then some lobular inflammation as well as ballooning degeneration. Now, the previously NFLD, or perhaps previously we were using NASH and subsequently NFLD, was actually a diagnosis of exclusion, actually. So we had to exclude causes of steatosis, important ones like alcohol and others. And primarily it was a disease of diagnosis by exclusion. But I think as things become more complex, and with the concept of methyl or metabolic associated fatty liver disease that came on, I think the diagnosis became a little bit more, had to be a bit more objective. So that's why I think the scoring system which you see here actually has been in use quite some time previously, although not in its present context. And it is basically a semi-quantitative scoring system whereby the degree of steatosis is given percentages and a score of 0 to 3. And I think in our case, I think it was quite a moderate to severe, being about 70%. So that's why it was given a score of 3. Now, as you're aware, when there is severe steatosis, there'll always be foci of liver cell necrosis, and this is where we get this lobular inflammation from. And depending on the degree of inflammation, you can get a variable degree of scoring. So in this case, it was given a score of 1. And the other point about NFLD is that not just steatosis, but the presence of ballooning degeneration, which is probably the more important feature of NFLD, because there are many causes of steatosis, but I think they would probably focus more on just the steatosis aspect, but not so much on the ballooning degeneration. So here, as we can see here, cells which are at very stress with fatty change, after a while it tips the balance and it becomes degenerated, and then they become ballooned out. So beyond microsteatosis and macrosteatosis, you have this foci of ballooning degeneration, which actually is important enough to be given a parameter. And as we can see back to the table, we have given a score of 2 because the score is just a 1 or a 2. Yeah. So all in all, the general scoring of the score, the semi-quantitative scoring system, actually enables us to make a fairly good diagnosis, reliable diagnosis of NFLD. And it indicates a moderately severe, although apart from the grading system, we also have this fibrosis score, which this is where I think we come to the role of the liver biopsy, as mentioned previously just now. I think liver biopsy has remained as the gold standard, but I think, as you are aware, it has been supplanted by various non-invasive tests, which has been mentioned previously for obvious reasons. And although it remains a gold standard, it becomes actually quite useful whenever we have to sort out some problems, especially like when there are atypical features, when there are things which you just the fibroscan cannot explain. For example, dual pathology, atypical features, clinical as well as histology. So this is where I think if we look at the case, the diagnosis of NFLD is quite straightforward here. Yeah. So although we considered the other differential of alcohol, but I think it doesn't come into the picture. And the more relevant issue here is actually to discuss what are the other features which are present in the liver biopsy. So if we can have a look at the case portal tract here, the present case, it's portal tract inflammation, as mentioned just now by Farhan. What we have actually is, in addition to this diffuse steatosis with hepatitis with ballooning degeneration, we also have portal tract inflammation. Now, NFLD per se actually shouldn't have a lot of portal, because it is not a portal-based disease. AIH is a portal-based disease, like hepatitis and all that, because this is where it starts from. And not only that, it also is a partly portal, partly lobular, whereas NFLD is more of a lobular inflammation, and things starts from the other end, the venous end. So this is where you have peri-sinusoidal, and as disease progresses, you will have those subsequent fibrosis, bridging fibrosis and cirrhosis. So the presence of this portal infiltrate raised the possibility of a possible AIH, also perhaps because of the strong history of autoimmune in this patient, the risk NA, and the fact that on histology, we do have this portal infiltrate, but as mentioned, it is not a very typical picture for AIH. So you notice that we're talking about portal kind of problem, rather than because we are coming into the related issue of this case, which is quite challenging and quite because it has an impact on management subsequently. Now, a typical picture of AIH would have all those chronic hepatitis features of interface hepatitis, rosettes formation, a lot of plasma cells, expanded portal tract. Now, although we talk a lot about plasma cells, the absence of plasma cells actually does not preclude a diagnosis of AIH actually. So previously, people see AIH as very heterogeneous disease, and clinicians have kind of designed very complex scoring system like the AIH scoring system, which is very cumbersome and would probably fit more in a research setting rather than in the routine reporting setting. So that's why we have currently a simplified scoring system for AIH, which actually is what we use to help us to give input about the possibility of AIH like in our case, for example. Now, as mentioned, we do not have those typical features. So if we have those typical features of interface hepatitis, a lot of plasma cell, lymphocytic infiltrate, basically a chronic hepatitis, we would give it a score of 2. And that score of 2 would probably go into, be configured into the simplified AIH scoring system, which has actually 4 parameters. My apologies, because I do not have that table, but basically they have a parameter for histology, 2 points, and points for serology, IgG, as well as Hep B status. Now, I think 4 parameters with 2 maximum, so that's a maximum of 8. So that's why I think, as alluded to earlier on in the presentation, they did try a scoring, and it came up with a possible of 6. Now, our histology is not typical. So actually, we would think that it probably deserves a 1 because it is perhaps compatible. It has some features of infiltrate which might be related to AIH. So beyond contributing that 1 point, it is up to the clinical, the use of that scoring system to come up with a possible diagnosis, whether it's a probable or definite AIH. Although I think even if we have a diagnosis of probable AIH, the final decision whether or not, because this is NFLD plus or minus AIH, and if it is a plus AIH, it has an impact on management, as subsequently, I think subsequent presenter will probably comment on. And it's entirely a clinical decision whether or not to go ahead with that treatment. So in conclusion, I think the diagnosis of NFLD is quite straightforward as per the liver biopsy. The only issue which has came up and we tried to clarify is that the role of that portal infertility might be have to be considered in the diagnosis of possible or probable AIH, and if we think that it probably merits a score of 1, and beyond that, I think it'll be up to the clinical decision. Incidentally, I think this case would probably be discussed further at the Gastro CPC later on. I think that will be there'll be further discussion on this, I suppose. So I think that's all from me. Thank you.
Thank you very much for the excellent explanation. It was very illuminating indeed, Prof. Isa. Just a thing that I wanted to highlight, this patient has been on prednisolone 5 milligrams every other day since October 22. So a question to both our expert, Prof. Isa, as well as Prof. Ros. Could this low dose of prednisolone have blunted the fulminant presentation of the histopathological aspect of AIH, resulting only in a very mild manifestation of AIH? Or are we happy enough to say that this is purely metabolic associated fatty liver disease and the portal tract inflammation alone does not satisfy the criteria for AIH according to the International AIH group for the diagnosis of AIH?
Can I just comment on that,
Sure.
Deborah? Yeah, so I think what is presented is very, very interesting and definitely pose some questions still on whether or not this is AIH. So what I will do is I will actually highlight what are the international AIH group diagnostic criteria has been right from the start when it was first posed. And I think what we want to do is really not say that that is not useful information, Prof. Isa, but just to say that liver biopsy should remain standard for the diagnosis of AIH, but perhaps the goal part has been questioned because we are moving towards non-invasive markers to diagnose and stratify NAFLD. So that NASH is really, like you said, is a histological diagnosis, but we are moving away because we have a huge burden, and I will show you the impact of NAFLD worldwide, as well as in Malaysia, that we need to move away from having an invasive test, but a non-invasive ways of stratifying liver disease status. So I'll share my screen. Yeah, so my focus that I will be talking about will be on NAFLD, but I also would like to share with you, some of the typical histological changes that are used by the International Autoimmune Hepatitis Group. So this is actually the 1999, from the beginning, if you can see in red, that the typical histological features to inform a diagnosis of AIH, it will be much more than just mild interface hepatitis. It has to be of moderate to severe intensity, both for definite and probable AIH. But more interestingly, and this is very recent publication last year, a consensus recommendations from the same group, which has been revised in 2022, which actually state again the same thing, that AIH is considered likely if there's more than just mild interface activity or more than mild lobular hepatitis. But I think what is highlighted that it must be in the absence of histological features suggestive of another liver disease. So I think a lot more on the biopsy has suggested that this person has got NAFLD clinically, but also features of steatohepatitis. And in the 2008, like you mentioned, the simplified scoring system, for the histology part, when it is not typical, when it comes to atypical, these are the actual scoring systems. So in this patient, I would think that perhaps it would be more consistent that we will stick to the others that has been shown by Gary earlier, but for the liver histology currently, it would probably be under the atypical group, which do not score additional based on the biopsy. We still need the biopsy to see whether this is compatible or typical, but currently it is considered atypical. So it is still a score of a 6, which means it's probable ARH. So some of you will question, are we depriving this patient because of the query still that we should be starting steroids in the patient? So I think if you look at the international guideline, before that. So this is another recent study published last year, which showed that it is not infrequent in patients with fatty liver disease to find changes which includes inflammation in the portal area, portal plasma cells, interface hepatitis, as well as biliary injury. But it's more likely to occur in those with advanced liver disease, fatty liver disease. So in terms of the steroid commencement in ARH, so this person has mild disease. ALT is actually definitely less than 3 times the upper limit of normal. In fact, it's just above the upper limit of normal. And also the person has comorbidities like we mentioned. And the third thing to say that we are not going to be starting steroids because we'll be focusing on the MAFLD part, but we'll be needing to review this. And this is something which is important. So I think we have to still keep at the back of the mind that this is probable ARH, and we'll be reviewing this from time to time. So I'm just going to focus now on fatty liver disease, and why I actually put the title as alarming is because it's been referred to as an epidemic of the 21st century. No doubt it is the commonest cause of liver disease, not just worldwide, but in Malaysia as well. And we know that it affects at least 1 in 4 globally, mainly adults, but we also see in children. And the risk factors here include the components of the metabolic syndrome. And this is an important point, which I will highlight again later. But I think we forget about some of the serious consequences. And Dr. Ho already mentioned the figures of 2 to 20% if you're already cirrhotic, that you can develop HCC. But more alarmingly, at least 50% presenting with HCC due to NASH are actually in non-cirrhotic. So what about prevalence in Malaysia? This routine health check showed 23% in healthy adults and up to 50% in patients with diabetes in this study. But this is again another alarming feature. In obese children, our study showed that nearly 80% of obese children have MAFLD, and some of them already had cirrhosis before the age of 10. And this is something that we should take note. Most of them have severe fat content or severe steatosis on the biopsy. So this is what we will really need to focus. It is a major health problem. It's mainly caused by overnutrition and physical activity. And what we found in Malaysia particularly is 1 in 2 adults have expanding waist circumference. So these are really the signs of modern times. And what I will show in the next slide is that MAFLD is rapidly becoming an even more important risk factor for development of primary liver cancer. So these 3 studies shows clearly the changing pattern in our underlying cause of liver cancer in this country. And what we can see here is hepatitis B remains the predominant cause of HCC. But if you see the changing percentage of cryptogenic, previously labeled cryptogenic, but we now know that it is most likely going to be NASH related or fatty liver. The latest study showed that 42% of our HCC are related to NASH. So this is one thing that we need to take note, and it will overtake hepatitis B very soon if it has not done so. So there's a high disease burden, particularly those amongst obese and type 2 diabetics, up to 90% of those with morbid obesity and up to 70% in type 2 diabetes. And this is another thing that we need to take note. We should look at MAFLD as a component an important component of NCDs with overlapping features, but also how to deal with it is also equally important that we look at it together, because as we now know that MAFLD identifies those at very high risk of cardiovascular death. And we know that the top cause of death in MAFLD is not liver-related, but cardiovascular disease. And on the right, this meta-analysis showed that nearly 45% of patients with MAFLD have underlying coronary heart disease. So this can be looked at. You not just identify MAFLD, but you also identify those at risk of cardiovascular death. So the spectrum has been highlighted of what the MAFLD consists of, and I think very clearly, NASH is not just a simple fat in the liver, it is also associated with ballooning, as mentioned and highlighted by Prof. Issa, and with or without fibrosis. And it's the fibrosis component that eventually leads to cirrhosis and impose a higher risk of HCC. And I again already mentioned that the biopsy has been the gold standard previously, but now we're moving to non-invasive assessment of liver fibrosis. Of course, FibroScan is ideal, but it's only present in less than 5 public hospitals in this country. So we do need to rely on other non-invasive markers. And why is it so important to look at this fibrosis measurement? Because studies have shown that this is the most important prognostic factor for liver-related death. And you can see clearly on the left that the liver-related mortality exponentially increased with increasing fibrosis stage. So those with advanced fibrosis, which is F3, or cirrhosis, F4, have the highest risk of death. And here, I'd like to just emphasize on the role of what we actually now commonly prescribe to be the simple blood-based biomarker for assessing presence of advanced fibrosis, which is FIB4. And here, what is clearly shown is that there is a way to know who are at high risk. If you have got someone with FIB4 of greater than 3.25, that predicts those with advanced fibrosis or cirrhosis. And in those with FIB4 of less than 1.3, it rules out advanced fibrosis with a good negative predictive value of 94%. Now, our study showed that you can further stratify those with intermediate risk, but I'll not go to that at this point, but just wanting to focus that why is that we are focusing on this. And I think Dr. Ho also highlighted in her conclusions slide that we not only need to screen, but we also need to stratify the liver disease status. And that's already been included in the latest CPG on the management of type 2 diabetes, that you screen using simple blood tests such as ALT and AST, and you stratify liver disease severity using the FIB4. So this is actually a simplified algorithm to actually not just screen for fatty liver, but also stratify risk using the simple blood test that I mentioned, ALT, AST, and platelet count. So your management or your referral pathway, if you are in a primary care setting, will be based on the FIB4 scoring. So here it is highlighted that everyone with fatty liver or metabolic risk factors would need lifestyle modification, would need management of their risk factor, and you may also consider cancer screening in a subgroup of patients. But more importantly, it's very clear who are the ones who can be treated at the primary care level, for example, and those who need to be referred to the specialist. So I will briefly mention about the management, because I think we will need to still focus on lifestyle modification, because currently there is no specific therapy which has been agreed upon by all guidelines to be used for patients with MAFLD, specifically NASH. So I think here diet and lifestyle changes have the best evidence, and it's mandatory in all patients, particularly those who are overweight and obese. And you can see from the bottom of the bottom row that weight loss as little as 3% can lead to steatosis improvement. But if you want to achieve NASH resolution or fibrosis regression, you need to lose at least 7 to 10% of the body weight. So achieving is one thing, but maintaining is another really crucial issue to be addressed. So very quickly, before I end, I will just show you the components of a lifestyle approach suggested, or rather recommended by EASL, the European guideline, which includes reducing daily alcohol intake, encouraging physical activity of at least 150 to 200 minutes per week of moderate intensity. We also need to look at the dietary components, which include, of course, crucial energy restriction, reducing or avoidance of fructose intake. This is the main culprit, which is leading to the obesity problem that we have, particularly in children. And we need to look at the macronutrient composition. And what is also equally important for the coffee lovers, there are data, evidence that increased coffee consumption can provide a protective role in fatty liver disease and also reduce the risk of HCC. So lastly, an integrated approach is needed. And I think we not just have to keep the liver in mind, but also look at cardiovascular risk reduction, screen and treat other comorbidities, consider diabetic medications that reduce weight as well. And for subgroup patients, consider also bariatric surgery. And lastly, a multidisciplinary team is crucial. And what is also important for us to think about is to engage primary care practitioners in our integrated approach to MAFLD. With that, thank you.
Thank you for the excellent presentation, Prof. So to tie everything together, this is a 43-year-old female with clearly demonstrated metabolic features. She has hypertension, dyslipidemia, diabetes, and she is obese, and she also has abdominal fat, which results in fat accumulation in the liver, manifesting as metabolic associated fatty liver disease. So the driver of her fatty liver disease in this case is the metabolic syndrome. And as we look from the HBE features as discussed by Prof. Isa as well as Dr. Farhan, we see that the criteria to satisfy the diagnosis of AIH is not met, as that is not the presence of portal lymphoplasmacytic infiltrate as well as lobular hepatitis of at least moderate features to suggest that this is AIH. Therefore, in conclusion, this is likely metabolic associated fatty liver disease as manifested by micro and macrovascular steatosis on the liver, which needs to be addressed by lifestyle modification. Another question as to why the ANA is positive in this paper is the fact that ANA can be positive as a result of an epiphenomena in which inflammation in the liver triggers autoimmune markers to be positive in the absence of an actual manifestation of an autoimmune floric disease. So I think Gary is going to just quickly summarize why that is ANA positivity and the prognostic significance of ANA positivity in patients with MAFLD. Over to you, Gary.
Okay, thank you. I'll just probably highlight 3 points related to the last part of today's presentation. The point number 1 is there has been studies which found associations between ANA and as a prognostic marker for fibrosis in biopsy-proven NAFLD. So this is one of the study. For the graph B, they noticed that when there's association between advanced fibrosis, F3 and F4, the yellow and blue box, between ANA positive and negative. And when they analyzed it, they found that there are nearly 4 times higher prevalence of advanced fibrosis in ANA positive patients than ANA negative patients. Then the next meta-analysis did mention about whether the presence of ANA can be an epiphenomenon in the occurrence of NAFLD. But they noticed an interesting part where they categorized this subgroup of patients, subjects, from different geographically regions. They found that it leads to diverse results. where in the Eastern populations, ANA positivity was associated with significantly elevated risk of significant fibrosis in NAFLD, but this was not found in the Western populations. So, in terms of the long-term outcome and survival of NAFLD in the Western population with NA, there was no relations in terms of the NAFLD severity. So the last part is about the postulated mechanisms linking the presence of ANA and the fibrosis in NAFLD. So there is a study by Yu et al. They explain that this association could include when there's presence of autoimmune antibodies, it stimulates multiple pro-inflammatory cytokines such as TNF-alpha and IL-1 beta, and this activates hepatic stellate cells, which contributes to the development of liver fibrosis. Another possible explanation by Luo suggested that production of autoantibodies in NAFLD may be a consequence of hepatic natural killer T cells accumulations, and this which has been reported to promote fibrosis in the various liver disease. So this is my last slides and my references.
Thank you, Gary. So again, to summarize, ANA is a poor prognostic marker in this patient, which indicates that she may be on an accelerated pathway to develop fibrosis as well as cirrhosis as a result of her metabolic associated fatty liver disease. Therefore, she will need close follow-up 3 to 6 monthly, and also stratification of her liver function test as well as her IgG. And should her liver function test deteriorate or her IgG levels elevate, a repeat liver biopsy is warranted to ensure that the fulminant features of AIH are not found in the subsequent liver biopsy. So with that, I would like to thank all the panelists as well as our colleagues for attending this CPC. I believe that we had a very good discussion today, highlighting important issues such as metabolic associated fatty liver disease, the utility of ANA as a poor prognostic marker, as well as the importance of lifestyle interventions and change in order to ameliorate the micro and the macrovascular steatosis in the liver. With that, I thank you for your time and attention.
Mr. Bukhari.
Okey, terima kasih. So saya akan switch on Zoom poll untuk undergraduate untuk undergraduate sahaja. Okey, terima kasih.